Good afternoon, and thank you for joining the Ohio Chapter American Academy of Pediatrics webinar focusing on Project First Line. This webinar will be recorded and housed on the Ohio AAP website. Following the webinar, I will be sending a link to the recording along with instructions for a short participant evaluation. Your feedback is greatly appreciated. Please mute your line so that we do not have any interruptions for the recording. Please use the chat feature to ask any questions or provide comments throughout the presentation. You may also go off mute at the end of the formal presentation to ask any questions. Our speakers today are Dr. Nicholas Newman, a pediatric environmental health doctor from Cincinnati Children's Hospital Medical Center. He is an attending physician of the Division of General and Community Pediatrics and is the medical director of the Pediatric Environmental Health and Lead Clinic. Dr. Newman is also an assistant professor at the University of Cincinnati Department of Pediatrics. Emily Groves received her Master's of Public Health and Infectious Disease Epidemiology from Columbia University in 2019. During her time in New York City, she worked for the hospital epidemiologist at the New York Presbyterian Morgan Stanley Children's Hospital in the Pediatric Infectious Diseases Department. And upon graduating in June 2019, she moved to Ohio for her current position as an infection preventionist at Cincinnati Children's Hospital Medical Center. Gladys Martinez is originally from Washington State. She completed her Master's of Public Health in epidemiology at the University of Michigan in 2019. She has been an infection preventionist at Cincinnati Children's since graduating from Michigan. Thank you all for joining us today. And with that, I will turn it over to Dr. Newman.
Hello, everybody. How are you? I hope you can hear me okay. You can hear me. So Project First Line is a collaborative led by the CDC to help provide training to first-line healthcare workers in public health in terms of preventing disease transmission. And as it says, the contents don't represent policies of the CDC and we're not being endorsed by the federal government. Next slide. And as Lori already said, we're recording this basically for educational purposes, and if people want to view it later. Next slide. And then I also received some funding through CDC, and but I'm not a spokesperson for either CDC or EPA. So what is Project First Line? Next slide. So it's well understood that infection control is really important in healthcare delivery. And COVID-19 has only given us like one more thing to worry about, basically. But the hope is that by participating in some of these training sessions, that we all get a stronger knowledge about infection control and be able to implement very straightforward control practices throughout work. And this is a collaborative effort between public health and healthcare. And as you can see, the folks who will be presenting today represent both clinical care and prevention and hospital infection control. And so the hope is that we start to build a little bit more capacity and knowledge around this. Next slide. So the objectives today and are kind of the subtitle for this whole talk really is infection control, focusing on the basics. So and what we want to do is put this in a bigger conceptual framework of how does epidemiology and exposure prevention go together? Because COVID has been such a big impact on so many things, we're going to spend a good amount of time really focusing on that, but routes of transmission. And then from the routes of transmission, how do we get into infection prevention? And what gives you the most bang for your buck? Next slide. And so now I'll pass it off to Emily.
I think Gladys is going to start with this part.
Yeah, so I do apologize if my video does go out, because it's been going out a few times right now, but okay, so in thinking about disease transmission, we need to consider the epidemiology of a disease. The epidemiology is the study and analysis of the distribution, patterns, and determinants of health and disease conditions in a defined population. One of the most common models that we use to observe and understand the spread of disease is the epidemiologic triad. The agent in this triad is the organism or microbe that is capable of causing disease. So for example, a virus, parasite, fungus, bacteria, things like that. The host is typically a human, though it can be other things such as like an animal. A variety of intrinsic risk factors can dictate how a susceptible host may be infected. The environment in the triad is just those external factors, such as favorable conditions or surroundings that may cause or allow disease transmission. This can be things such as socioeconomic factors, environmental factors, and biological factors. This model may vary from disease to disease as to which may have greater weight or pull in producing disease, but ultimately, all three interact in a way that produces disease. Next slide. So here we just have an example of what like COVID as seen in the epidemiologic triad. Again, the agent is SARS-CoV-2, the host would be people, the environment is just the environment. Next slide. Okay, so it might not be easy always to be able to define where we might be able to modify the interactions between the host, the agent, and the environment. So the chain of infection describes that those interconnected steps that are needed for the agent to create disease in the host. As indicated by kind of like the colors here, there's a relationship between, again, that the triad and the chain of infection. So the agent, when considering the agent, you have to consider the factors that may be intrinsic to the agent that might help it evade the disease, such as how pathogenic or virulent it may be. Next in the chain is the reservoir, which is where an infectious agent may normally live and multiply. In some instances, this reservoir isn't always a susceptible host. It can also be like, again, environment or animals. Next in the chain is the portal of exit, which is just the way that the agent kind of leaves that reservoir. For example, with COVID, it'd be mainly through like the respiratory secretions and droplets. Next in the chain is the mode of transmission, which is how the agent will get into the host to create disease. Transmission can be direct, indirect, or through the air. And for COVID, transmission seems to mainly be through like droplet, which is larger particles that are greater than those like 5 micrometers and that don't travel very far in the air. Airborne, which is those smaller particles that may stay kind of more airborne and travel further, or contact, which is maybe just contact with the surface of where those respiratory droplets might have settled. Contact is the least likely mode of transmission. Next in the chain is the portal of entry, or how the agent might enter the host. Often an agent will enter through the same way it entered the host, but that's not necessarily always the case. For COVID, it can be through the introduction of the respiratory tract. And then finally, we have the host, which again is the people. A host susceptibility may depend on their age and their comorbidities, such as if they're pregnant, if they have chronic respiratory issues, if they're immunosuppressed, just those other coexisting health conditions. Again, infection doesn't automatically occur when an agent enters the host, especially if that agent is not very pathogenic. But if you are immunocompromised, you're at a greater risk of infection than a healthy host. In infection control, we're always considering the ways in which we may break the chain of infection. So thinking which ones make sense versus which ones don't make sense. Typically, we focus on how we might be able to prevent an exposure. Next slide. Okay, so here we have the hierarchy of controls, which is defined by NIOSH as a way to control exposures to occupational hazards to protect workers. Those which are higher up are the most effective and protective control methods when compared to those further down in the pyramid. Elimination is physically removing the hazard. Substitution is replacing that hazard. Engineering controls is isolating people from the hazards. Administrative controls is just changing the way people work. And finally, PPE is just like the protective, personal protective equipment that's available. When thinking about COVID, although elimination and substitution are high in this list of effectiveness, they tend to be difficult for healthcare workers to control for, because although you can oftentimes like reschedule an appointment and try to make them more virtual, that may not always be an option. So you might rely on those that preventative things that are lower down on the hierarchy. Next slide. Next is Emily.
I'm going to talk about the basics of infection control. So infection control measures have been instituted in healthcare for a while, but they have been under a giant lens during this COVID pandemic. So working in infection prevention and control at a hospital, we have heard some very creative and complex infection control methods that have been proposed to us. A quick Google search or briefly turning on the TV, you'll see a number of these creative ideas. And this can be very overwhelming for people who are just looking for one right answer to protect themselves, to protect others. And you can really get lost in a rabbit hole very easily. So our objective has been to really stick to the basics, make sure we are following 100% the tried and true evidence-based methods of infection control. So our goal, like Gladys said, with all pathogens, not just COVID, is preventing and controlling infection. This here, like Gladys said, is the chain of infection. It's essentially the life cycle of infection and transmission. And the way to prevent and control transmission is to break the chain of infection through any one of these stages. Next slide. So in order to break the chain of infection for a certain pathogen, you have to understand how that specific pathogen is spread. So for coronaviruses like SARS-CoV-2, it is generally spread through respiratory droplets. Droplet transmission occurs when tiny drops from either a sneeze or a cough, or even talking and singing, float through the air from person to person. Next slide. And there are a few different aspects that can affect the effectiveness of transmission routes. And while it may not feel like it as much anymore, COVID is still very novel, and we do not know everything there is to know about this virus yet. There are many active areas of research, and like we've seen multiple times over the past year, things can change very quickly based on new evidence. But we know that COVID is transmitted through respiratory droplets. Droplets generated from coughing, sneezing, and talking are heavier droplets that do not linger in the air. These droplets can be more easily transmitted the closer contact you are with someone, the type of environment you're in, like being outside versus being in an elevator or being in a clinic room. There is some evidence that under certain conditions, people with COVID seem to have infected others who were more than 6 feet away or were in the same space shortly after the person with COVID had left. And these transmissions occurred within enclosed spaces that had inadequate ventilation. And while situations like this have been noted, available data indicate that it's much more common for the virus that causes COVID to spread through close contact with a person who has COVID rather than through airborne transmission. And additionally, respiratory droplets can land on surfaces and objects, and it is possible that a person could get COVID by touching a surface that has the virus on it and then touching their own eyes, nose, or mouth. But this is not generally thought to be a common route of transmission and can also be avoided by things like hand hygiene. So focusing our efforts on the routes of transmission that are most effective is very important. Next slide. So our goal is always to prevent transmission. So how can we modify the host, the agent, or the environment to prevent COVID transmission? Next slide. So going back to our basics of infection control, we can apply this to breaking the chain of infection for COVID. The first method, I'm sure, is well known to all of us at this point, which is PPE. This includes masks, eye protection, gown, and gloves. This protective equipment can break the chain of infection by both blocking the portal of exit from the infected host or by blocking the portal of entry to the uninfected host. We also know that COVID is spread through respiratory droplets, and there are a few ways that can interrupt that mode of transmission for COVID. So by performing hand hygiene, you are removing or killing the virus from your hands, which can serve as a mode of transmission into your eyes, nose, or mouth. By social distancing, you are creating enough space between you and someone else so the droplets cannot physically get to the next portal of entry. And by cleaning and disinfecting surfaces, this eliminates the potential for surfaces to be fomites, which are objects that can carry infectious agents and aid in transmission. And then lastly, and probably the hottest topic right now, if you are able to get the vaccine, this makes a host no longer susceptible to infection, thus breaking the chain of infection. Next slide. And we can see how the hierarchy of controls is tied to the chain of infection and how we can apply this to COVID infection control. So starting at the bottom of our hierarchy, PPE can be effective at covering our portals of entry and exit. But in a clinic setting, if you're able to, it might be more effective to control the way people work and switch to telehealth to limit the amount of time that you are in contact with others. Even more effective would be also isolating people from the hazard by putting up physical barriers or shields like plexiglass. And replacing the hazard doesn't really apply to COVID, but possibly the most effective method in healthcare would be, if you're able to switch to telehealth because you are physically removing the hazard. And it's important to note that all of these interventions aren't always feasible at all times in all situations, but they don't need to be instituted all together all the time to be effective. Combination of a few as a bundle can still be very effective at reducing the risk of transmission. And now I'm going to hand it over to Dr. Newman to educate us about cleaning and disinfecting.
Hello. So what is the purpose of disinfection? We kind of wonder a little bit, because there's been a lot of talk about like cleaning and sanitizing, et cetera. So if you want to just go forward, Lori, yeah. So the purpose of disinfection is to eliminate the infectious agent, like somehow disrupt it so that it starts to break down and it's not going to be infectious anymore. And in the case of COVID, for example, you have this this lipid envelope, which is actually fairly delicate. And so disinfection is one way that you can break the chain of infection. Next slide, please. But if we remember, particularly early on in the pandemic, like people were cleaning everything, and cleaning off their grocery bags as they were coming in, like everything they touched, so that, and in part, like people were doing that because some early studies showed that the COVID, the SARS-CoV could, stay like kind of intact on hard surfaces and cardboard for days. And it isn't that cleaning is bad in itself, okay? But as Emily was talking about, I mean, the transmission is possible from these items to other people. Like, if someone like gets all this snot in their hand and they touch something and then you touch that thing and then you touch your nose, well, that's certainly that's like a possible way of transmitting, but it doesn't seem to be, as strong a means as compared to respiratory droplets. But frequently touched surfaces and hands seem to be really important in terms of where this, may occur, right? So, but the problem with cleaning. Next slide, please. The problem with cleaning and disinfecting is that, if you look here, these are calls to poison control centers starting in 2020, and you can see, like, right as we began to lock down in March, there was this big increase in basically people calling saying like they've been injured or ingested either like cleaners or disinfectants, which is quite much higher than the baseline level. So this is not where we want to be going. I mean, we're trying to prevent infection, not cause people to get injured from cleaning and disinfecting things. Because that's like another like chain of disease that we're trying to like not get started, right? So the next slide, please. So what exactly do cleaning, disinfecting, and sanitizing mean? So like cleaning basically is removing like dirt and grime and germs, but it doesn't necessarily kill the germs because it depends on like the type of chemical that you're using to clean with. So like, for instance, everyone's familiar with the the COVID that, like kind of, the sphere that they always put up, and it's got these little spikes sticking out, right? So in order for like, let's say cleaning or soap to destroy the COVID, that like little soap molecule needs to pass in between some of those spikes, and it needs to be able to disrupt the lipid envelope and like kind of blow the thing up, right? And there's actually some research going on right now at a couple of different centers trying to understand like, what size cleaning particle can fit in there, and could that be a way that we could try to reduce some of this? Disinfecting is using a chemical specifically, or a process, to specifically kill germs on a surface or in like the laundry, right? And people are familiar with a whole bunch of like disinfection products, and they all have like similar things that basically like they subject whatever the infectious agent is to some kind of like a chemical that disrupts it. Like it either like breaks through the membrane, or it desiccates it, it dehydrates it basically. And then sanitizing basically is kind of a measure of like how well these other things are doing, right? So sanitizing is that you're trying to lower the number of germs to a safe level per like what public health is saying you need to have it below in order to prevent something from being transmitted. So and with this, so some of the early work, there's SARS-CoV-2 on a surface. Well, we don't know like how much needs to be there in order for this to be propagated. And it turns out like, yes, there is some on surfaces, but it actually decays off fairly quickly. So like what's actually there after a few days is a lot less than what you started with. Next slide, please. So how to do it? So like the idea is like you clean first, because if there's a bunch of dirt there, then the disinfecting chemical can't work effectively because it may be bumping in, on a molecular level, it's bumping into all these other things that are preventing it from getting to where it needs to go. And the other thing that disinfection takes is time. So like there's something, called a dwell time. So like when you apply something, it doesn't just work instantaneously. It needs time. And so depending on the chemical, let's say hydrogen peroxide or something, like if you put that on, like you have to wait for that, you have to get a certain concentration of it on there, but then you also have to wait for it to dry out. So like it isn't just like you put it on and like kaboom, it's gone. It takes time for it actually to do its work. And that work can be interfered with if the surface isn't like clean enough to start. So in some ways, like, when they say like, oh, well, you can use like a hand sanitizer as long as your hands aren't like obviously soiled. Well, like that's the whole point. Like, because if they are obviously soiled, then the sanitizer isn't going to be able to do what it needs to do because it's being interfered with by these other things that are there. Next slide, please. And so the EPA, US EPA, came up with an N list. And can you just like tap once? Because that'll bring up a little animation. So like at the time that I put this on here, this was maybe a couple weeks ago, there were 535 things on the N list. So if like you're looking for a disinfectant, most people look at that and they just scream. They're like, oh my gosh, like, and my favorite stuff isn't on there. I can't find it. All right. So let's go to the next slide. So this end list is really like the ultimate list of stuff that we're quite sure is going to kill COVID because it's been known to kill other viruses that are really similar to COVID. But if you're looking for less irritating disinfectants, things that maybe aren't going to be respiratory irritants or their lower skin irritation, then there's a short list that actually so far we know seem to be helpful in killing off COVID. So you don't have to use like the atomic bomb to get rid of it. Like, ethanol will kill it. Isopropanol will kill it. Hydrogen peroxide. And these things are less, in the concentrations that we tend to use in like a healthcare setting are much less like irritating. And if you're having to disinfect things all the time, this becomes actually a problem because it isn't like, oh, I did this once a day. You might be doing it 20 or 30 times a day. And so that exposure over and over again is what causes the problems. And it's important to actually look at the label and see like what chemicals are on there, because there are a number of companies who are making all kinds of claims about some of these chemicals. And so you want to be well informed. Next slide, please. And then, of course, there's bleach. And bleach works quite well, but we do not want to, you don't want to just like, you want to mix it properly, because that's what the problem is like people say, oh my gosh, yeah, I use the bleach and it makes it makes me cough or my lungs hurt. Well, that means that you need to ventilate it, and you also need to make sure you're using the proper amount. The other thing, and I forgot to put this on here, besides like the things that you see here, is that bleach has a shelf life. It's actually fairly short. So like once you make up the bleach solution, you need to use it like within about a day or so. So it isn't like you make it and you leave it, because the bleach is, the way it works is it reacts with these agents these infectious agents to chemically deactivate them. But it also like interacts with the air, and light breaks it down and stuff like that. So and it's also important not to combine with other products. Next slide, please. So how important is cleaning and disinfecting? It's important, but it shouldn't like get in the way of the other things that we know that work very well, like source prevention, like wear a mask. So you're covering the portal exit, right? Maintaining distances from people, because those respiratory droplets don't go that far. Wash your hands, because that's where most of the stuff gets to you. And then if you have someone that you know is sick, you want to try to keep them separated. Next slide, please. So what about hand sanitizers? One of the issues is that you need to use enough ethanol, because some of them are really low concentration, and that's not going to be effective enough, because ethanol basically dries out the virus. You should not eat it. There has been a whole bunch of ingestion problems with this, and actually pets, people have sprayed them on pets too. Like they'll absorb it through the skin. It's very bad for them. And then because their skin is different than ours. And then you have to watch out for these like black market hand sanitizers. There's people like always selling stuff. Like I know I work in a city, and you see like there's this guy who sells stuff on a street corner. He's made up like some kind of disinfectant stuff in like little bottles that he found around the house. I don't really know what's in there. I know people who use it. I'm like, I don't know if I'm going to use that. So you just want to be careful that you're getting reputable stuff. And I think we're turning over for the scenarios to Gladys and Emily.
Yeah, so working in infection control, part of our job is to be a resource for clinicians to answer questions in real time. And especially over the past year, we've received tons of calls regarding COVID. And we just wanted to share a few of the most common scenarios and kind of how we've handled them. So this first one, you're examining a patient accompanied by his mother. Patient and mother are both asymptomatic. And after being roomed, mom informs you that she tested positive for COVID 4 days ago through routine testing at work, but has remained asymptomatic. Would this knowledge change your infection control precautions? And Laura, if you just want to hit next. We would say no. Masking and eye protection are universal for scenarios such as this. There's always potential that you'll come into contact with someone who's COVID positive, even if they are unaware that they may be COVID positive at the time. So combined with proper hand hygiene, transmission risk in a scenario like this would be really low. Next slide. But what if mom is symptomatic? Would this then change your infection control precautions? And we would again say no. Mask and eye protection are adequate PPE to protect you against symptomatic persons, and the transmission risk would still be very low. Next slide. So another common scenario that we see, you are seeing a patient who is accompanied by her father. Father reports that the patient was exposed 3 days ago to a cousin who is COVID positive. Would that knowledge change your infection control precautions? Laura, if you just want to hit next. And we would say no, that your precautions wouldn't change. Same as the situation before, masking and eye protection are universal for scenarios such as this. And there is always potential that you'll come into contact with someone who could be COVID positive. Some patients know they're COVID positive, some know they've been exposed, but most do not. So that is why we're protecting ourselves at all times. Next slide. Another common question we receive, especially during the early stages of the pandemic, was regarding employees who were COVID positive. So in this scenario, one of your front desk workers becomes symptomatic while at work. They leave to be tested and result positive for COVID. And this employee has been at work all week. Would you need to deep clean and close your clinic to do so? Laura, if you just want to hit next. We would say no, it's really not necessary to close your clinic and deep clean. As Dr. Newman mentioned, COVID can live on surfaces, but standard cleaning of the office would be sufficient to kill COVID on those surfaces. And then as far as exposures to other employees, this is why we're universal masking, as I've said before, and that PPE would make transmission risk very low. And then I think we have a few feedback questions for the group that Dr. Newman was going to go over.
Yeah, hi. So there's just a couple of questions. This is just to make sure we're getting like our point across. And I think there's only a handful of people on the call anyway. If you don't mind putting in the chat like what you think the best answer is. So the question is, the most important mode of transmission of SARS-CoV-2 is A, airborne, B, close contact, or C, surfaces. So A, B, or C is the. All right, awesome. Yeah, I think there's only 2 or 3 people on. So yeah, next, can you just tap it, Lori? Yep, yeah, so close contact is the most important because that's where those respiratory droplets tend to live, or fairly close. Next slide. Less toxic disinfectant such as hydrogen peroxide and citric acid are effective against SARS-CoV-2, like true or false? Awesome. Yeah, so that's great. Yeah, next, just hit the thing. All right, yep, yeah, so that's true. Yeah, thanks to everybody. We got 100%. That's awesome. But truthfully, like these questions seems pretty basic, but like this has been like places we've really gotten stuck during this this pandemic. So next slide. I think the next slide is just, yeah, we're just opening it up. So feel free to unmute and turn your video on if you're so inclined. If there's questions for the 3 of us about this, or things you'd like to hear in the future, we're happy to come up with other stuff too.
I have a question. Can you guys hear me?
Mm-hmm.
So for eye protection, so I'm a general pediatrician here in Cincinnati. With rates being decreased a little bit, is it still recommended that we wear eye protection with every patient, or not? What's the current guideline for that?
As far as I know, it's still recommended to keep the eye protection on for the time being. I know some of the hospitals locally have relaxed a little bit, meaning like you don't have to wear it like everywhere in the building. But I think it's still being recommended like in like close contact with patients. Emily, is that right?
Yeah, I really only know for Cincinnati Children's, but there's been no talks about lifting that kind of PPE requirements as of yet.
It's interesting because it was a study. I mean, like a lot of the studies coming out now around COVID, like I think we're going to reflect back on the quality of these things maybe in the future. But there was a study like from healthcare workers like early in the pandemic from Asia somewhere, I can't remember which country, where they found that healthcare workers who were wearing like even glasses had a lower transmission than those who didn't. So and those mucous membranes we think are probably one of the main portals of entry. So like it's not inconceivable. I don't know personally like how much of the the ACE2 receptors in your eyelids or whatever, but I do appreciate the fact that it gets to be a little cumbersome trying to like look through, like because I'm trying to look through my glasses with the progressives plus like this on, and I'm trying to look in some kid's nose. So like I totally get where you're coming from.
Well, and we're vaccinated, right? So like everyone, all of the physicians and nurse practitioners are vaccinated. And so that's the challenge is, yeah, they fog up and they're hard to wear. And so it's hard to know what the right guidance is, because initially, at least, it was, I don't know if it was from ODH or CDC, was kind of like when infection's high or whatever, and they didn't give us an exact number, like you should wear eye protection and whatever when community transmission is high. So I don't know what that means.
Right. We're still like, I mean, Hamilton County has come down a lot, but I think we're still like well above like, because we've gotten so used to it being so like crazy. But I think, I don't know, I'm trying to like hold out a little bit longer. I mean, basically, I mean, I have to do what they tell me to do, but I think, hopefully there's a light at the end of the tunnel soon.
Thank you. I appreciate you answering my question.
Yeah, no, that's fine. And actually, I wrote it down because like we were going to take like things that come up and like try to make sure that like either that gets incorporated into another talk or it gets out on our like social media. I know Lori had a couple of ideas about how to get stuff out. So there were a couple other people.
Do you have any thoughts about double masking if you've been vaccinated?
So the double masking thing, like, so my other like hat I wear is I study bioaerosols over at UC. Like that's one of my things I do. And I think and from what I've read and what I know from some of the work we've done, a well-fitting mask is probably better than like multiple masks, like period. So I think the focus should be on trying to get like what you have on to fit well, because one of the problems is like as you create more resistance, you get more like air coming in from like around it. Like, particularly with surgical masks, which really weren't necessarily designed to have multiple layers on. So I would focus on trying to make sure it's fitting properly. And the study that CDC published was, I think the problem was like, you have to look at it in context. They looked at like one particular kind of mask and one, and when you read the recommendations in there, like they did really stress the fit. So that's where I would emphasize it. But I don't know if Emily and Gladys have other, because you're dealing probably with these questions a lot.
Yeah, we talk about this a little bit. I think a lot of that double masking was geared toward being out in the community where transmission is very high. And then also our masks that we wear every day, just the ear loop masks, those are already more than one layer. So we've already been double masking, if you want to think about it like that. That's really all I had to add on to what you said, Dr.
Yeah, I was gonna say, like, yeah, our surgical masks already like meet the standards if you're just thinking about like here at Cincinnati Children's, and so that's why we've never made that recommendation of double masking.